Welcome, everyone. You have tuned in to Dentist's Coffee Time.
Hello and good morning.
We are so glad you're here, whether you're taking a quick break between patients or maybe diving deep into a complex case that's sitting in your chair right now.
And we have a topic today that really gets to the heart of those complex cases. It's what separates a straightforward aesthetic job from a truly challenging one.
Absolutely. We're talking about facial asymmetry.
And more specifically, the rules, the really rigid rules that govern how we should be looking at it.
Right. So our mission for this deep dive is to figure out the hierarchy. I mean, what's actually most important when we look at a human face? We've gone through sources that, frankly, they force us to challenge some long-held beliefs.
Especially the idea that the vertical midline is king.
Exactly. We're going to unpack that vertical axis, the facial midline, and then we're going to put it up against what our sources call the unyielding supremacy of the horizontal plane.
That level line, the one that dictates everything from the patient's bite, the occlusal plane, to just the overall sense of harmony.
And it's especially critical when a patient's face is already skewed or, crooked.
It's such a critical distinction because when you're faced with asymmetry, you have to decide which line you're going to trust.
And if you choose the wrong one?
Well, if you trust a skewed vertical line, you're basically building that deviation right into your final result.
Yeah, okay.
But if you pick the wrong horizontal reference, you're violating one of the most fundamental principles of how we as humans see the world. So today is all about the rule book for getting predictable, cohesive results in these really tough aesthetic situations.
All right, let's dive in.
Let's do it.
Okay, let's unpack this and start at the beginning with the vertical axis. So the facial midline. Our sources often call this conceptually the DOM line. But before we get into its importance or lack thereof, let's just nail down the definition. How do we find it?
The definition is actually quite specific, which is interesting given how it's treated later. It relies on two main anatomical anchors. The DOM line is defined as the line that extends from the central point right between the eyebrows.
So the glabella region.
Exactly.
Yeah.
From there, it goes straight down to the central point of the upper lip, and specifically, the very center of the Cupid's bow.
So we're connecting a bony landmark up top with a soft tissue landmark down below, and that Cupid's bow. That's essentially the middle of the philtrum, right?
That's right. Unless, of course, you're dealing with a patient who has something like a history of a cleft lip or palate. That would obviously change how you define that soft tissue center.
Sure, that makes sense.
So it gives us pretty reliable starting and ending point for a vertical check. But, defining it is the easy part.
Hearing
Understanding its actual aesthetic weight. That's the real challenge. And this is where the source material introduces a concept that is, I think, foundational for this whole conversation.
And this is where it gets really interesting for me, because right away, the vertical midline, which we all learn about, it gets demoted.
Immediately demoted. Exactly. Yep. The source is explicit. The DOM line, the vertical facial midline, does not have what's called a cohesive force.
A cohesive force.
It doesn't have the power to visually hold the face together. In fact, it's the opposite. It tends towards a dispersive force.
Okay, let's stay on that term for a second. Dispersive force. It sounds very scientific, but what does that actually look like in the clinic? I mean, why is the midline inherently dispersive?
Think about it from a perception psychology standpoint. We as humans are actually very tolerant of small vertical mistakes.
You mean like if a smile is a little off-center?
Precisely. Studies have shown that a vertical midline deviation, where the two front teeth don't line up perfectly with the center of the face, can be off by up to 2, maybe even 3 millimeters.
And people just don't notice.
Or it's tolerated. It gets masked by everything else going on, the curve of the other teeth, the way that the lips move, the whole three-dimensional structure of the face. That tolerance is the dispersive nature. It doesn't scream error at you.
So our eyes are just more forgiving vertically. We can handle something being a little off-center because our brain is busy prioritizing other things.
Yes. So if that midline is slightly off, it's often just a secondary concern. It's a minor detail, not the main thing that determines if a face looks harmonious or not.
Which means if we're building a hierarchy of what's visually important,
the vertical midline has to be secondary. The visual shock of a midline being off by 1 millimeter is nothing compared to the shock of seeing a smile that's tilted.
The unlevel horizontal plane.
That's the one. And this establishes the golden rule right up front. The horizontal line, that sense of parallelism, is the most important factor in how we perceive aesthetics. We're trying to maximize cohesive force, and that force lives on the horizontal plane.
But this idea of demoting the midline, It must have come from, I imagine, a long and frustrating history of people trying to define it. The sources even mentioned old German textbooks from the 90s where this was a huge point of confusion.
Oh, it was a very messy period
Mm.
because clinicians were desperately trying to find one single, stable, vertical reference point that just, well, it doesn't really exist.
What were some of the biggest mistakes people were making back then?
One of the early errors was trying to anchor the midline to something like the midpoint of the face's total width,
Why is that a bad idea?
because soft tissue and muscle aren't symmetrical. What might look centered when a patient's face is relaxed can shift completely when they smile or talk. It's just not a reliable measurement.
And then there's the big one, the one I think clinicians still need to be warned about, using the nose.
The nasal bridge. This is the critical error to avoid, and it's one that gets perpetuated by all those perfect idealized diagrams in textbooks.
Right, the drawings always show the midline passing perfectly through the center of the nose.
But in the real world, the nose is one of the most asymmetrical parts of the face for so many people.
Because of a deviated septum, or they broke it playing sports as a kid.
Exactly. The vast majority of people have some kind of nasal deviation. So if a clinician uses a crooked nose as their guide for the dental midline,
They're intentionally aligning the teeth with something they already know is wrong.
you're building an error into the plan from day one. It dramatically increases the dispersive force because now the teeth look off-center compared to, say, the eyes or the chin. It's a planned mistake.
So, if the nose is out and the width of the face is unreliable, what are the modern accepted ways to find this vertical midline, especially when a face is already looking a bit asymmetrical?
Today, in modern digital planning, we really lean on two stable anchors, and they both come from what's called the T-effect principle.
The T effect. Okay.
The first, and this is the most critical, comes from the eyes. We establish the interpupillary line.
So, a straight line connecting the center of the two pupils.
Correct. And the vertical midline is drawn perpendicular to that horizontal line, passing right through the exact midpoint between the pupils.
Ah, so it creates a capital T. That's the 90-degree relationship between the foundational horizontal line and the vertical one.
That's it. You establish the horizontal first, and the vertical is derived from it. The second point, which is more of a confirmation, is the center of the Cupid's bow, or the tip of the philtrum.
And ideally, those 2 points, the one from the pupils and the one on the lip, should line up.
They should. And if they don't, the clinician has to make a judgment call about which one will create a more cohesive final result. But you generally prioritize the one derived from the T-effect.
The source also mentioned that software can help with this, right? Like, once you define that intercupillary line, the program just does the math for you.
The digital tools are fantastic for precision, but they don't change the philosophy. The key takeaway from this first part, I think, is that even though we find the midline very precisely, we have to always remember that a little bit of deviation is okay.
It's tolerated.
It's tolerated, and we have to be prepared to accept a slight vertical deviation if it means we can achieve a absolutely perfect horizontal alignment. Because horizontal mistakes are totally unforgiving.
That sets the stage perfectly. So now we know the vertical line is dispersive and secondary. Let's get into why a face becomes asymmetrical to begin with, which is all about diagnosing the deviation by segment.
Right. Understanding that hierarchy is one thing, but it's pretty useless if you don't understand the pattern of the asymmetry you're looking at.
Because a crooked face isn't just one diagnosis.
Not at all. It shows up in different segments. And the right treatment, whether it's just some crowns or orthodontics or even major jaw surgery, depends completely on figuring out which segment is the real source of the problem.
Okay, so let's walk through the 3 main patterns of deviation the sources highlighted.
The first, and a pretty common one, is a skeletal deviation that's only in the lower third of the face.
What does that look like?
In this case, the patient's upper and middle face, so the eyes, forehead, nose, cheeks, they all look pretty straight and symmetric. But the lower face, specifically the chin and the jawline, is visibly crooked. It deviates to one side.
So they have a nice level top half, but then their chin point is just noticeably off-center.
Exactly. It's often an issue with how the mandible grew or maybe a localized trauma. Diagnosing this properly involves, a PA cephalogram X-ray to see how much is bone versus how much might just be the teeth compensating.
And the treatment for something that severe would probably lean towards surgery to move the lower jaw back into position.
If it's a true skeletal issue, yes, repositioning the mandible to match the stable upper jaw.
Okay, so that's pattern 1. What's the second?
The second is when only the middle segment is off. So the upper face is straight, the lower face is straight, the eyes are level, the chin is centered. But that whole central region, basically the nose and the part of the maxilla around it, is crooked.
That sounds like it would be really frustrating to treat aesthetically.
It's one of the most frustrating, especially if it's from an old injury or a really bad deviated septum. Because if the main problem's in the middle of the face, any attempt to line up the teeth with the nose just...
You're back to that planned mistake.
Exactly. You're just adding another crooked line to the face. This is where the interpupillary line becomes so vital because it acts as your sanity check against that skewed central part of the face.
And for that kind of problem, you're probably not doing major surgery. It's more about camouflage with orthodontics or veneers to minimize the visual impact.
Precisely. You're managing the visual fallout of the problem rather than fixing a big skeletal issue in the jaw itself.
Okay. And now the third pattern, which sounds like the biggest challenge of all, the one that really puts this whole hierarchy to the test.
This is the one. Overall asymmetry. This is where multiple segments are crooked, and it includes the highest aesthetic reference point we have. The source gave an extreme example where the eyes themselves are not level. They're slanted, or one is higher than the other.
And this is the critical scenario we have to plan for.
Absolutely.
Yeah.
Because if a patient comes in and their eyes are tilted, meaning their interpupillary line is not parallel to the ground, then the entire foundation of that T effect you just talked about is gone. It's compromised.
This is a face where that dispersive force is just...
It's running rampant.
Let's expand on that. When you say the dispersive force is running rampant, what does that mean for the person looking at that face? What's the visual experience?
Our brains are constantly trying to find anchors. We're looking for stable, predictable lines. When you see a face where multiple big features are all off kilter, the eyes are tilted one way, the nose is crooked another way, the jaw is off to the side, the brain can't put it all together. It can't find a single cohesive picture.
It's like visual noise.
That's a perfect way to put it. It's visual noise. And the whole goal of our aesthetic treatment is to silence that noise. The more things that are skewed, the louder that dispersive force becomes.
So the amount of dispersive force is basically tied to the number of non-parallel, non-centered lines in the face.
I think that's a great way to frame it. And so the treatment plan has to be all about maximizing the cohesive force. We have to intentionally introduce a line that is so perfectly level and centered that it forces the observer's brain to anchor the whole face to that new stable reference.
And that stable reference is the smile.
If we can create one universally accepted, perfectly level horizontal plane, the correct occlusal plane, we dramatically reduce how distracting all the other crooked features are.
So telling the difference between these patterns must require some pretty detailed imaging. You can't just eyeball it from a photo.
Oh, absolutely not. This is where the deep diagnosis happens. We're using things like PA-CEFs to check the skeletal symmetry of the jaws. More and more, we use 3D cone beam CT scans, CBCTs, to measure bone volume, the symmetry of the jaw joints, and critically, the height of the orbital rims.
So you can actually measure if the eye sockets are at different heights.
Exactly. We need hard, quantifiable data to prove that the eye skew is real and it's skeletal, not just a soft tissue illusion.
Which brings us to the moment of truth. Once we've confirmed the patient is in that third most complex category, overall asymmetry with tilted eyes, we have to face the philosophical cornerstone of the whole treatment.
Which is the horizontal plane. If the vertical midline is secondary, the horizontal is primary. And if the patient's own eyes are now part of the problem, part of the dispersion,
We have to find an anchor somewhere else. An external, reliable, non-negotiable, cohesive anchor.
and that anchor is the ground beneath our feet.
Let's take a deeper look at that non-negotiable anchor, the ground plane, and really explore why it overrules everything else, even the patient's own eyes. Okay, so we've established the horizontal line is paramount. Let's talk about the why. This goes beyond just what looks nice. It's apparently rooted deep in our biology. Why is the human visual system so incredibly sensitive to horizontal errors?
It's all about how we're conditioned by our environment. I mean, we are creatures that live on the ground. Our entire world is defined by gravity, by the horizon, by flat surfaces. So our non-negotiable built-in reference for what is level is the ground plane.
It's not a learned preference. It's an instinct for survival and orientation.
It's an evolutionary imperative. It's how we orient ourselves in space.
And this brings us back to the building analogy, doesn't it? If we see a building and the roof line is tilted, it triggers a kind of stress signal. It looks wrong, unstable.
Dangerous. Exactly. A tilt of just 1 or 2 degrees in something that should be level, whether it's a building or a smile, is instantly registered by our brain as a mistake because it violates that fundamental expectation of stability.
And that sensitivity is why parallelism is the single most powerful tool we have in aesthetic treatment.
It is. If the occlusal plane is tilted, the whole face looks tilted. It instantly maximizes that dispersive force, no matter how perfect the vertical midline is.
But this leads us right into the great clinical conflict, the big dilemma. What do you do when the reference we normally use as a stand-in for the ground, the interpupillary line, is itself crooked? The eyes are lying to us.
This is the moment of truth for the clinician. We rely on the eyes because, in 90+% of cases, they're parallel to the ground. They're a great shortcut.
But in that 10% of really complex cases,
the interpupillary line is tilted. And if you decide to make the patient's bite plane parallel to their skewed eyes, you are consciously and permanently treating them into a state of horizontal deviation from the rest of the world.
the source mentioned a historical debate on this, like a philosophical vote among experts on how to handle this exact problem.
It's a fascinating conflict because it pits different clinical philosophies against each other. The debate was all about how to define the correct occlusal plane when the eyes are visibly slanted. And there were basically three camps.
Okay, what was the first position?
The first, which some older textbooks seem to suggest, was to set the occlusal plane parallel to the patient's own skewed interpupillary line. The thinking there was, I guess, to maintain some kind of internal consistency with the patient's features.
So trying to make the smile fit the existing asymmetry, like a camouflage.
It is, but it's a camouflage that ultimately fails. Because any outside observer with normal horizontal perception looks at that smile, and their brain registers it as tilted against the ground. It actually increases the visual stress. The internal consistency of the patient's face doesn't matter if the result is inconsistent with the entire environment.
Okay, so that option is out. What was the second?
The second, which is the one that won out and is the correct choice, was to set the occlusal plane parallel to the true ground or the horizon.
Regardless of what the eyes are doing.
Regardless.
Yeah.
This position says that the observer's perspective, which is anchored by gravity, has to overrule the patient's unique individual asymmetry.
And there was a third, more theoretical option, right? The anti-parallel one.
Yes, the idea of setting the occlusal plane tilted in the opposite direction of the eye skew. It was an attempt at an optical illusion, hoping the brain would sort of average the two tilts out. But it's wildly unpredictable, it's too complex, and you risk creating two opposing errors instead of one.
So the consensus came down firmly on trusting the ground, not the eyes. Can you walk us through the rationale one more time? What's the real-world implication of making that choice?
Okay, let's imagine a patient whose left eye is visibly, say, 3 millimeters lower than their right eye.
Okay.
If we make their occlusal plane parallel to that tilted eye line, the left side of their smile will also be 3 millimeters lower than the right side, relative to the ground. So every time they smile, an observer will see that their teeth are slanting downwards on one side. It's a major aesthetic flaw.
And if we align the smile parallel to the ground instead?
The smile instantly gains that cohesive force. The observer's brain sees the most prominent line, the line of the teeth, as level, stable, and harmonious. Now, are the patient's eyes still uneven? Yes. But by anchoring the smile to the ground plane, we've made the eye asymmetry a much less dominant, much less distracting feature. We're introducing stability into the chaos.
That is a profound philosophical shift. But how do we do it practically? How do you establish the true ground plane in the clinic? When the patient is sitting in a chair, maybe their head is tilted, you can't just look out the window for the horizon.
That's a great practical question. This is where we have to look for a surrogate horizontal reference, a secondary line that is also parallel to the ground, but is less likely to be skewed than the eyes.
And the source offered a specific one.
Yes. The practical substitution is to check the commissural line. That's the line connecting the two corners of the mouth when the face is at rest.
And why would the mouth be more reliable than the eyes in these cases?
It's fascinating. It seems to relate to skeletal stability versus muscle function. The position of the eye sockets can be affected by growth issues, by trauma to the cheekbones. But the maxilla, the upper jaw, which supports the corners of the mouth, is often a more stable, unrotated base. The commissural line is heavily influenced by gravity and the resting tone of the lower facial muscles, so it very often stays level with the ground, even when the eyes are tilted.
So, to put it all together in that critical hierarchy, if the interpupillary line is skewed, step 1 is you ignore it. Step 2 is you check the commissural line. And if that line is level with the ground, that becomes your new target for the occlusal plane.
That is the rule. The ultimate priority is not matching the patient's features, it's parallelism with the ground plane. If the eyes are liars, we substitute them with the most stable level feature we can find, and that is often the mouth.
It's a difficult decision, though, because you're consciously making the bite plane not parallel to the eyes.
It requires confidence, but it's necessary to achieve that visual cohesion. You have to stand firm against the patient's existing anatomy to maximize the visual benefit for everyone who will ever look at that smile.
And in the end, that's what maximizes the patient's own satisfaction, because the final result just feels right. It feels stable.
It connects everything. We're making sure the face, at its most visible point, follows the universal laws of perception.
Okay, that brings us perfectly to our final synthesis. Let's connect all these ideas and lay out the final, actionable hierarchy for everyone listening.
All right, let's summarize the hierarchy of reference. This is really the key to tackling any case of facial asymmetry. First, the primary reference. This is the source of all cohesive force.
And that is?
Always the horizontal line, parallelism with the ground. This rule is absolute. It overrules everything else.
And its whole purpose is to reduce that visual noise, that dispersive force.
Correct, which brings us to the secondary reference. This is the one that's prone to dispersive force, and that's the facial midline, the vertical axis.
You have to measure it accurately, but if it's a little off, it's far more tolerable than a horizontal tilt.
Exactly.
So let's just quickly revisit how these lines play together in a normal non-asymmetrical case, the ideal textbook patient.
In the ideal scenario, it's beautiful. Everything is aligned. The patient's interpupillary line is perfectly parallel to the ground. The commissural line is parallel to the interpupillary line. The T effect is perfect. The dental occlusal plane lines up with all of them, and the vertical midline you get from the pupils lines up perfectly with the cupid's bow. It's a symphony.
So in that perfect case, using the interpupillary line is a completely reliable shortcut for the ground plane.
Precisely. It's easy, it's convenient, it's almost always accurate, and that's why it's taught as the default reference.
But the moment we diagnose that complex overall asymmetry, the one where the eyes are tilted,
that's when the clinician has to execute the asymmetry management rule. This is the exception that proves the rule of horizontal supremacy.
you have to consciously override the interpupillary line.
You must. Using it would just bake the error into the final result. It would amplify the dispersive force.
And so the clinician goes looking for a substitute horizontal reference that is still parallel to the true ground plane.
Exactly. And that substitute is very often the commissural line. If the corners of the mouth are level, we use that as the target for our new occlusal plane.
And what if? What if everything is skewed? Eyes, nose, mouth, all of it.
In that rare extreme case, the clinician has to rely on external tools, leveling devices, careful measurement of the patient relative to the gravitational plane, to the floor. You have to find that non-negotiable, universally level horizontal line, even if you have to create it artificially.
You know, this whole philosophy, this move away from just following the patient's existing anatomy to instead imposing an external universal reference, that must require a lot of confidence and really good communication with the patient.
It absolutely does. It requires educating the patient and sometimes their family or even other doctors that the aesthetic goal isn't to perfectly copy what's already there. The goal is to introduce cohesive stability.
We're treating the visual perception of the face, not just the anatomy itself.
That's it. By prioritizing the horizontal plane, we are fundamentally redesigning the visual experience of that face to maximize harmony, even if it means some parts, like the smile, are intentionally made non-parallel to other parts, like the eyes.
It's a powerful reminder that complex aesthetic work isn't just about following a checklist. It's about making deliberate, prioritized choices based on universal perception. You're correcting chaos by introducing an absolute order.
And that order is rooted in the gravitational stability of the world we all live in. The less dispersive force you have, the more the entire face just looks anchored and centered and beautiful.
This has been an incredibly detailed breakdown. It really gives our listeners, I think, the confidence to handle those tough cases where the patient's own features seem to be betraying the rules of aesthetics.
That's it.
And that brings us to the end of this deep dive. But before we sign off, I want to leave everyone with a final thought to chew on, something that connects these clinical rules back to the human experience. Given that we've learned the human eye prioritizes horizontal parallelism above all else, how might a minor uncorrected horizontal skew in a patient's smile affect their long-term psychological satisfaction, even if the treatment achieves perfect functional results? Think about that constant subconscious conflict between good function and that deeply ingrained visual habit of seeking a level horizon.
That's a critical question for all of us to consider as we plan our next cases.
Thank you so much for joining us on Dentist Coffee Time.
Bye-bye.